The following podcast is part of a certified educational activity titled All Rise for Innovation in AML, Processing New Developments with Menin Inhibitors in Challenging AML Subtypes. Access the entire activity and complete the post-test at peerview.com/WFS860. Downloadable slides are also available.
Hello, everyone. I'm Dr. Gus Issa from the MD Anderson Cancer Center in Houston. Welcome to All Rise for Innovation in AML, Processing New Developments with Menin Inhibitors in Challenging AML Subtypes. I'm pleased to welcome my colleague, Dr. Naval Daver from MD Anderson, to this discussion. Today, during this program, we will take a look at the status of menin inhibitors for acute myeloid leukemia, particularly in light of the evidence presented at recent meetings, but also attempt to map out the future use of these novel therapeutics. We are also providing a downloadable summaries of these guidelines and dosing information we'll cover today as a practice aid. So you may want to access this resource now. Let's begin. So our goals for today during this presentation, you will learn that menin inhibitors have the potential to address previously unmet needs in challenging AML subtypes. We'll also talk about the clinical evidence that support their use as single agents and as part of combination regimens, and that menin inhibitors may soon play a role in the frontline management of acute myeloid leukemia, including in high-risk settings. So we are excited about menin inhibitors because the main subtype, or one of the subtypes that we're targeting, KMT2A rearranged acute leukemias, have an adverse prognosis. Prior to the advent of menin inhibitors, we had no great options. For patients that are diagnosed with KMT2A rearranged leukemias, the incidence is roughly up to 5%. It could be higher in children. The 1-year overall survival is roughly 50%. The 5-year overall survival is less than 25%. The median overall survival is around 13 to 15 months. So certainly we needed better therapies to treat this subtype, especially in relapse and the refractory setting. So currently, KMT2A rearranged leukemias are included in the ELN guidelines as adverse risk. There is a distinction in the ELN between translocation 9-11 that causes KMT2A MLL-T3 fusion as an intermediate risk, and all other KMT2A rearranged leukemias as adverse risk. What I would note is that this applies maybe to high-intensity chemotherapy and young patients, but my summary or my take, as well as many of my colleagues, is that all KMT2A rearranged leukemias have an adverse prognosis, and all should be considered for consolidation with a stem cell transplant. Now, regarding NPM1 mutant acute leukemias, which are the other subtype that we're targeting with menin inhibitors, while they have a favorable prognosis when newly diagnosed, once in the relapse and refractory setting, NPM1 mutations have no prognostic value. This is work that I've done with my colleague, Dr. Daver at MD Anderson. So we show, based on our retrospective analysis at MD Anderson, that in patients who have relapsed or refractory disease, the outcome of NPM1 mutant is similar to the outcome of NPM1 wild type. In other words, once leukemia has relapsed with NPM1, it is as bad as any other leukemia, and we need better treatments for this subtype. There could be a benefit of the addition of venetoclax in patients that had not received venetoclax as part of their frontline strategy or even as salvage. So in this limited analysis, we showed that there is an improvement in overall survival in salvage when venetoclax is added. So venetoclax-based therapies could be an acceptable salvage option. But currently we have menin inhibitors as an exciting new therapeutic class, or an exciting new class of drugs that could be important to treat KMT2A rearranged leukemias or NPM1 mutant acute myeloid leukemias. And there are multiple menin inhibitors currently in clinical development, with the menin inhibitor revumenib approved for relapse or refractory KMT2A rearranged leukemias in patients or infants, so age up to age 1 year and above. The menin inhibitor ziftomenib has currently been submitted for regulatory approval for NPM1 mutant acute myeloid leukemia, relapse refractory NPM1 mutant acute myeloid leukemia. And this is based on the pivotal phase 2 study that we're going to discuss as well in this talk. Additionally, there are the menin inhibitors from J&J, pleximenib, the menin inhibitor from Sumitomo, enzomenib. And I think the menin inhibitor from Biomea Fusion has stopped development for acute leukemia. So we would not focus on this menin inhibitor. So menin inhibition or menin inhibitors work by disrupting the binding of key proteins, so menin and KMT2A, because these two proteins are critical for the aberrant gene expression that happens in either KMT2A rearranged leukemias or NPM1 mutant acute myeloid leukemias. So these small molecule inhibitors create a wedge between the protein menin and the other protein KMT2A, and that leads to turning off the aberrant gene expression, OX genes, and that leads to differentiation and an anti-leukemic effect. And now Dr. Daver, my colleague, will take you through the clinical evidence that supports menin inhibitors in acute myeloid leukemia.
Thank you very much, Dr. Isa. Very nice outline of the menin biology and field and how we're developing these menin inhibitors as you outlined. I think both for relapse refractory KMT2A rearranged and relapse refractory NPM1, there is a huge unmet need with outcomes that still remain less than 1 year overall survival. And this is where we think the menin inhibitors will eventually improve that outcome for our patients. So these are the NCCN guidelines here, showing menin inhibitors now already included for relapse refractory acute myeloid leukemia, with revumenib being the first menin inhibitor approved for KMT2A rearranged. We're hoping we will see many more menin inhibitors coming into this list in the near future for not just KMT2A rearranged, but also NPM1 and potentially other subsets like NUP98, PCOM, and other menin-sensitive aberrations. So let's go through some of the data that supported these approvals. This is the phase 2 Augment 101 trial that looked at revumenib in relapse refractory KMT2A rearranged population. This was the final efficacy population that was supporting the approval of this drug. Dr. Isa and Dr. Aldos were the leads who presented some of this data. And we see here the overall response rate, which to me is very important because this allows us to get patients into some sort of remission, enabling them to proceed to allogeneic stem cell transplant, which is always the proximate goal of treatment in relapse refractory AML. And this was above 60%. So a lot of our patients with these therapies will be eligible for a transplant, which was not the case before the menin inhibitors. A CR/CRh rate, meaning a response with full or good count recovery, in about 25%, and negative, minimal, or measurable residual disease status in about 60% of the responders. So these are really compelling single agent response and efficacy data. Of course, one can also see that there is a flip side where the CR/CRh rates are 25%. So we need to improve on that. And we think that this will happen with combination therapies that we will talk about. The duration of response is about 6 to 7 months. This is very much in line with the duration of response seen with other targeted therapies in relapse refractory AML, such as FLT3 inhibitor, gilteritinib, IDH inhibitors. And so this did lead to the FDA approval of revumenib currently as a single agent for KMT2A rearranged disease. So revumenib is also shown to be effective against relapse refractory NPM1 mutated AML. This is the data that has now been published very recently in 2025 with 64 patients, relapse refractory NPM1, showing here again a CR/CRh rate of about 25%, along with an overall response rate of close to 50%. Many of these responses are durable, especially in patients who are able to achieve remission, proceed to transplant, and do post-transplant menin inhibitor. Even in relapse setting, second and third salvage, we are seeing young patients who are able to achieve long, durable remission and hopefully will eventually lead to potential cures. This is now looking at the baseline co-mutations and how these may impact the responses to the very menin inhibitor revumenib. Here we can see that patients who have underlying IDH mutations seem to actually have a good response and not statistically significant, but appears to be a trend towards encouraging responses in this population overall. We're also seeing that in patients who have FLT3 mutation, there seems to be no big difference in terms of response rates. Response rates are maintained. Now, of course, we do not have yet durability of response in OS. That will be very important to look at, as well as the baseline FLT3 allelic frequency or burden. But it does appear that menin inhibitors do have activity in FLT3 mutated. And of course, this opens up the concept of an idea of potentially even combining them with FLT3 inhibitors, which is now ongoing in various trials. RAS mutated patients do seem to have slightly lower response rate. This is something we have seen with RAS in the presence of FLT3 IDH venetoclax. So we will have to see over time whether combinations may be able to better overcome that. So this is now looking at another menin inhibitor, the second menin inhibitor that went into clinical development called ziftomenib. Ziftomenib has predominantly been focused on the NPM1 mutated AML, where it showed the best response data. And this is the data from the completed phase 2 and pooled phase 1b2 data set showing an overall response rate here of about 35% and a CR/CRh rate of 25%. Very similar, as you may recall, to the CR/CRh rate that has been shown with revumenib in relapsed refractory NPM1. Duration of response here is ranging from around 4 to 6 months, also in a similar range to what has been shown for revumenib in relapse, as well as for other targeted therapies, and MRD negativity in about 60 to 70% as well. Now, we are similarly seeing that there appears to be a good response and clinical benefit of revumenib in relapsed refractory NPM1, regardless of the baseline co-mutation status. Patients who have a FLT3 mutation seem to be having responses, especially the TKD. And again, IDH co-mutated patients seem to actually have a trend potentially towards higher response rate. This is something that has been shown biologically very recently, that IDH mutations, especially IDH1, may be sensitizing patients to the menin inhibitor, and is something we will need to study in greater detail. And even in patients who have had prior transplant, and most importantly, patients who have had prior venetoclax are continuing to have a maintained response rate. Now, this is not necessarily true of other treatments where prior venetoclax exposure and failure often results in lower response rate. Importantly and encouragingly, with the menin inhibitors and ziftomenib, we are continuing to see good and maintained response rates even with prior venetoclax treatment. So now let's move to what I think is going to be the future use of these menin inhibitors, which is the combination strategies, as well as the newer emerging menin inhibitors that I think will also be important players in the near future. So at MD Anderson, with Dr. Issa leading this efforts, we've developed a study called the SAVE study, which is a combination of 3 drugs, the revumenib, the oral decitabine, and venetoclax triple therapy. This was based on preclinical data showing a strong synergy between the HMA venetoclax and the revumenib. And we are seeing now in a single-arm study in early data, but very encouraging response rates. These were multiply relapsed refractory patient, median of salvage 2 and 3. Many of them have had prior venetoclax, and we're seeing overall response rate of 80%. But really, even more importantly, we're seeing a CR/CRh rate of close to 50%. If you will recall, the CR/CRh rate with single-agent revumenib and single-agent ziftomenib was right around 23-25%. So if this holds up, we're basically seeing close to double CR/CRh rate, which of course is important because this response is usually associated with better survival as well as better ability to proceed to transplant. Many of these responses are MRD negativity, and in fact, probably because of this high response rate and better count recovery, we're able to get more patients to transplant. Here, actually 40% of all patients, so 13 out of 33 have gone to transplant. With single agent, this number is close to 15-20%. So the transplant rates are better with this combination and hopefully will lead to longer term survival. And we are looking forward to these updates in the near future. Similarly, the efforts are ongoing, as you would expect, to move the menin inhibitors into the frontline setting, both in combination with azaven and intensive chemo. This is frontline data generated by the BEAT AML Consortium looking at azacitidine venetoclax, which is the established and approved frontline standard of care for older unfit AML, and adding to it revumenib menin inhibitor in patients who have a menin-sensitive target mutation aberration like NPM1, KMT2A rearranged. They have shown the data at the European Hematology meeting in June 2025, showing a very high overall response rate, close to 90%. And impressively, we're seeing that majority of these responses happen after one cycle, and a large proportion of these patients had MRD negativity. And as you can see from this plot, the response rates were high across age groups below and above 75, across KMT2A range and NPM1. I will say, though, that one of the things we are a bit concerned about here is the duration of venetoclax of 28 days. In most other combinations where we have added a targeted therapy to backbone HMA-VEN, we have had to reduce the venetoclax down to 21 or often 14 days to avoid prolonged and cumulative myelosuppression. And I think it will be important to see how the myelosuppression is managed and if there are any early toxicities or mortalities with the prolonged venetoclax, and potentially reducing that venetoclax in the future iterations of this study. But at this time, good response rate, good MRD negativity, and proof of concept suggests the combination is synergistic for AML clearance. Similarly, now, of course, there are efforts to also add menin inhibitors to the standard backbone of intensive chemotherapy, which in the United States still at this point is 7+3. This is ongoing with various menin inhibitors. Ziftomenib is the first one to have shown the data. This was presented at ASH and showed in 51 newly diagnosed patients who have an underlying KMT2A rearranged or an NPM1 with adverse risk, which was defined basically as co-occurring high-risk ELN cytogenetics and or age above 60 years of age. Those patients were given the backbone 7+3 with the addition of ziftomenib in a dose-escalating fashion. They did eventually establish the dose at 600 milligrams ziftomenib added to the standard backbone of anthracycline cytarabine 7+3. This is now the efficacy data from that study, and they have shown that overall the response rates were quite high, in the range of about 95%. So very impressive. And this was true, in fact, not only for NPM1, which we do know can give you high response rates with just intensive chemo, but even KMT2 rearranged, where response rates usually tend to be around 60 to 70%. We're seeing CR/CRc rates touching 90%. So to me, that is very impressive, especially the KMT2A rearranged response data. Of course, we need to see durability and OS. The follow-up was short, about 6 months, and this has not yet been reached. But so far, it looks like a number of patients are maintaining remission visually looking at the swimmer's plot, and hopefully this will translate into a good duration of response and overall survival. Now, there are new menin inhibitors coming. Bleximenib and enzomenib are the two that I will talk about. And there are certain differences potentially in terms of tolerability as well as maybe efficacy with these. Bleximenib is being evaluated in combinations with azacitidine venetoclax in both relapse refractory and frontline. We haven't seen yet the full data set for all patients treated, but from the data that was presented at EHA, among the efficacy valuable subset, they are reporting an encouraging response rate in both relapse refractory, but even more so, I would say, in the front line, where again, the response rates are close to 90% with CRc rates of about 65 to 70%. Now, how this will compare with standard therapy, I think we will have to see in ongoing frontline registration studies. Here we're looking at the split between the KMT2A rearranged and NPM1 mutated, treated on the aza-ven bleximenib at the recommended phase 2 dose. I'll draw your attention towards the newly diagnosed AML. Here we do have a few KMT2A rearranged where the overall response rate was 70%, and NPM1 mutated where we're seeing a good overall response rate with a CRc rate of 63%. So I think these data are looking encouraging. Of course, we need more durability in OS data, and are leading to a frontline randomized study that will evaluate this triplet versus the standard of care aza-ven placebo, and this study has just been initiated. Similarly, there are efforts at looking at bleximenib with 7+3. This is an early study ongoing at this time. The data was presented at the ASH meeting. Here we're seeing a very high overall response rate, 20 on 21 patients, and there were no major toxicities in terms of differentiation syndrome or DLTs or major QTC prolongations. Again, looks like we can deliver these menin inhibitors, whether it's ziftomenib or bleximenib, even on the backbone of intensive chemotherapy with close monitoring and dose adjustments. And now there's a fourth menin inhibitor, enzomenib, that we have been working on closely here at MD Anderson. And we are seeing that this drug seems to have quite a favorable safety profile. Now, with more than 100 patients treated, no DLTs have been observed, and we do not see any significant QTCF impact with this drug. And differentiation syndrome, which seems to be the common side effect, class effect that has been seen with menin inhibitors, seems to be different with each drug. With the enzomenib, this seems to be quite manageable. We also have been aggressive in how we identify and treat the differentiation syndrome, but overall rates are about 10%, with grade 3 differentiation syndrome of 5 to 6%, and no major discontinuation or mortality events from DS. So safety profile here is quite good. Then the overall response rates here, the numbers are smaller than the other menin inhibitors, but hopefully will be updated at upcoming meetings. And we're seeing CR/CRh rates for relapse KMT2A of about 30%, relapse refractory NPM1 at 47% at the doses that seem biological active. And this study also is now initiated as a registration single-arm study in relapse refractory KMT2A rearranged. So with that, I'm going to turn it back to Dr. Issa to discuss a couple of cases here.
Thank you, Naval. So we'll talk about practical insights on the present and future of menin inhibitors in AML, and we'll specifically discuss a few cases. So the first case is a patient with relapsed KMT2A rearranged AML. So Bertrand is a fit 60-year-old man with a diagnosis of AML. At diagnosis, he had no FLT3 or NPM1 co-mutation, but was found to have KMT2A rearrangement with a translocation 911. So this patient was treated with standard of care 7+3, achieved a complete remission, however, relapsed 18 months. After treatment, he presented with bone pain and had low counts. And at that point, the bone marrow biopsy confirmed relapse with genomic analysis or cytogenetic and molecular analysis showing, again, the translocation 911. So, assuming a menin inhibitor is chosen, what are the safety considerations to prepare for? And what have we learned from the clinical experience to date? Naval, what do you think?
Yeah, good. So good question. I think starting is, what are the options for this patient, right? So definitely menin inhibitors, one of the key options in the mix. I think the big question is, would I do a single agent, or would we do a single agent menin inhibitor or combo? We don't have mature enough data to make a very definitive stance on this, but the patient is fit. He's 60-year-old. He had a 1.5-year remission. My goal is to get him to transplant. So I expect a finite duration of therapy, and I want something with the maximum response and depth of response. So I do think here I would be looking more at a combination. The question then is, what combination? Would I go with HMA-VEN combination? Would I go for an intensive chemo-based combination? I think the data so far is more supportive of an AZA-VEN menin, such as the SAVE study, AZA-VEN revumenib. That's probably my approach here. With transplant, consulted early, plan to give 2 to 3 cycles, achieve a deep MRD negative remission, proceed to transplant, and very importantly, plan for post-transplant maintenance in this population. I will say, one could consider approach such as a FLAG-IDA-VEN here. And as you know, in our group, we have discussed such patients quite a bit over the last few years, and the response rate and data with that regimen is also quite high, up to 70-80% in this setting with good durability. So I think these are both going to be good options, but with the data from SAVE, and I would love to get your thoughts on that, becoming more mature, I think an option of HMA-VEN menin to me is starting to look more and more appealing to get to transplant. What do you think?
Yeah, I agree with you. I mean, the standard of care right now would be single agent revumenib. And as we discussed, the chances of response are with the CR/CRh about 25%. And we're hoping with these combinations that we're doing, such as SAVE, to improve those chances of response, but also improve depth of remission. And in this case, in relapse refractory setting, there absolutely we need a second transplant. So I would favor a combination. I think SAVE is well tolerated. It's leading to excellent responses. So I'll probably favor that. And especially that I think that the combination of venetoclax and menin is highly synergistic. And I favor that over, high intensity chemo in a lot of the cases, because it's leading to high responses across menin inhibitors across studies. So Naval, what do you think about side effects? What were, let's say, you chose a single agent menin inhibitor, let's say revumenib. What are the things you watch for?
Yeah, that's very important. So with any new drugs comes a new set of learnings and side effects. So with the menin inhibitors, I'll point out three key ones that I think in the community, especially if these drugs are used, one should be aware of. So differentiation syndrome is probably the most important. It is a different differentiation syndrome than you see with IDH and arsenic. It can occur earlier, it can occur later, and it tends to be more explosive and severe in some patients. So if you see somebody start a menin inhibitor within the last few weeks, they start having increase in white count, neutrophils, or monocytes, shortness of breath, new skin rash, LFT changes, sudden increase in creatinine, bone pains, lymph node pain. These may be manifestations of differentiation syndrome. So rather than stop the drug, I would try to add steroids, dexamethasone twice a day, and see as a stress test whether that improves the symptoms. If it does, then this likely was differentiation syndrome. And usually you can continue the patients on treatment. In some patients, you will see that no, the blasts keep going up, the disease is progressing, then that can be considered as disease progression. But very important to not miss the DS. The second is QTC prolongation. This seems to be more of an issue at this point with revumenib. We haven't seen it as much with the others. So you have to do the EKG monitoring as recommended in the package insert, as well as avoid concomitant QTC prolonging medications if possible. And the third is myelosuppression. So we are seeing now with prolonged use of these drugs, especially in patients with ongoing remission, that we can see myelosuppression. So if we start to see somebody who's achieved a response but is having very low platelets, neutrophils, we may want to consider a short interruption or a dose reduction to mitigate the myelosuppression.
Yeah, this is great. So we can move to another case. Adela is a 77-year-old woman with a diagnosis. She had NPM1 mutant acute myeloid leukemia. Also, the mutational analysis showed a FLT3 TKD. Because of her age, she was, and some comorbidities, she was thought to be not eligible for intensive chemotherapy. So she received standard of care, azacitidine and venetoclax, and achieved a complete remission with MRD negativity. However, 14 months after azaven, she had a relapse. And at relapse, she still had, or the leukemia still had NPM1, and FLT3 TKD is still detected. So what do you think, Naval? What would you do here?
Yeah, so these are kind of the real world scenarios where we have a lot of patients who have more than one targetable mutation. Now, this patient has a TKD. I think this is an important point for me. The TKDs tend to not be very as proliferative or be driven by the mutation as compared to the FLT3 ITDs. And this patient, as we see with many TKD mutated patients, had a response, maintained it for a while and relapse. So the two options here, obviously, if we're looking for on-label options, are revumenib for the NPM, well, not yet, but hopefully in the near future, revumenib or ziftomenib for the NPM1. Both of these are under FDA review, or gilteritinib for FLT3 TKD. So to me, in this patient, because the TKD is not such a powerful driver, and because we're seeing very good single agent activity with the menin inhibitors, I would be more inclined towards a menin inhibitor approach, either as a single agent or potentially as a combination. I think if this patient had an ITD, then I would be a little bit more leaning towards the FLT3 inhibitor, such as gilteritinib. So I think here I'd go more for a menin inhibitor, potentially in a combination. What are your thoughts, Gus?
Yeah, I agree with you. I mean, hopefully the data with combination of menin and FLT3 would mature soon and would show us whether this combination is synergistic. Certainly, in preclinical models, using a menin inhibitor and a FLT3 inhibitor makes a lot of sense. Menin inhibition affects transcription of FLT3, and even in the case of a FLT3 TKD here, it could be activating. You could use a FLT3 inhibitor that would block the receptor activation, and the menin inhibitor would block the transcription. So both may have a synergistic effect, but we have to still wait for the clinical results and see if this is improving on either agents or if the combination is safe. Now, if we take both scenarios, Naval, those two cases that we talked about, would you consider a clinical trial frontline with a menin inhibitor for these patients?
Absolutely. I think, both patients, if I knew at baseline, especially for KMT2A rearranged in the fit 60-year-old, I would be looking for a frontline menin inhibitor containing regimen, whether it's with intensive chemo plus the menin or HMA-VEN plus menin. I think that is a major disease and prognosis driving aberration, and addition of menin inhibitor to me is kind of very critical in the frontline setting. And I think a lot of data is already starting to show that we can really change the outcome for KMT2A fusions and KMT2A rearrangements in menin. I think for the frontline NPM1, it's trickier again because you have two regimens now. If you're looking at emerging data, HMA-VEN with the FLT3 inhibitor like gilteritinib, or HMA-VEN with the menin inhibitor. I think again here, given that it's a TKD, I think I would be comfortable and okay to go with a menin inhibitor. But if one wanted to do HMA-VEN FLT3, I don't think that's wrong. The data from our group, from Dr. Short, published in JCO, shows very good outcomes in FLT3 TKD mutated with that triplet. So I think both are going to be good options, but I would definitely look for adding a targeted therapy in the frontline setting, and emerging, maturing data seems to show that outcome is better and better with more time.
Thank you. Yes. So now I will take you through some practical considerations on each of the menin inhibitors that are currently being used. So specifically about revumenib, revumenib had been developed for children and adults. That's why the dose is adjusted by weight for children age less than 12, or for weight less than 40 kilograms. Dosing of revumenib is done by BSA. For adults, it would be 160 milligrams with a strong CYP3A inhibitor and 270 milligrams twice a day without. That's also because revumenib is affected by CYP3A, just like venetoclax. In other words, if you're using POSA, you would need less of revumenib because the concentration in the blood would be a little higher. Now, regarding ziftomenib, it was investigated mostly in adults, with the studies in pediatrics still ongoing. So the dosing is not adjusted by DSA for children yet. The indication is for adults. It would be a one-time daily dose of 600 milligrams. Bleximenib is, I think they just reached their recommended phase 2 dose, and that would be 100 milligrams twice a day. There is a step-up dosing that they conceived in the study to try to mitigate the risk of differentiation syndrome. And for enzomenib, the recommended phase 2 dose is 300 milligrams BID for KMT2A rearranged relapsed or refractory AML. And there is an ongoing registration study, as Dr. Dover mentioned, for this subtype. So, in summary, the differences between these menin inhibitors, I would just say that the data is robust. It's showing the preclinical activity of menin that we suspected is demonstrated in these clinical trials with a CR/CRh rate between 25 to 30%, and overall response rate reaching in some cases 60%. There are some side effects that are particular to each menin inhibitor and some class related side effects. So the class side effects are differentiation syndrome, possibly myelosuppression. The menin inhibitor revumenib has an effect on the QT, and it is grade 3 in 10% of the cases. That requires, as per the package insert, monitoring with EKGs, electrolyte monitoring, and minimizing medicines that could prolong QT, or monitoring whenever we use them. The menin inhibitor ziftomenib has a differentiation syndrome rate of 15%. Bleximenib had similar differentiation syndrome rate and no clear effect on the QT. And as Dr. Dauber mentioned with enzomenib, so far the rate of differentiation syndrome seems to be less, and there's no clear dose adjustment needed by azole so far, and no effect on QTc prolongation. So in summary, we see that these menin inhibitors represent an opportunity to use targeted therapies for the largest subtype of acute myeloid leukemia, or the largest fraction of acute myeloid leukemia. Revumenib is FDA approved for KMT2A rearranged relapse and refractory acute myeloid leukemia and is now included in the NCCN guidelines. And there has been a submission for approval for the NPM1 mutant relapse refractory acute myeloid leukemia to the FDA. Ziftomenib is also submitted for regulatory approval to the FDA for relapse refractory NPM1 mutant acute myeloid leukemia. We are seeing activities across these menin inhibitors, especially in combinations. So this data is really exciting, and we have more and more evidence that supports use of these menin inhibitors in the frontline setting. That's why multiple phase 3 trials have been launched to see if the addition of menin inhibitors to standard management of newly diagnosed acute myeloid leukemia would improve outcomes. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by educational grants from Johnson & Johnson, Kura Oncology Incorporated, and Syndax. To access all materials for this activity, visit peerview.com/WFS860.